So let me just quickly share. Let's see if this works. Yeah, can you see the presentation? I hope it works. Perfect. So so you may know me already. I'm the organizer of the conference, and I also present some of my work. And yeah, I'm really happy that I have such a huge audience today. So my background is actually in pharmaceutical science. I did a PhD in pharmacy, but I'm also a sociologist and STS scholar. And I work here at the University of Tübingen and at the Center of Gender and Diversity Research. So I chose the talk Gordian Knots in Health Equity through AI, and I would like to take some threads that we already had during the conference and maybe weave something, ask some new questions and offer some perspectives, some new perspectives. So we've heard a lot about fairness during this conference. It was also in the conference title, of course, so there's many talks that were dealing with discrimination and fairness. And so interestingly, I would like to propose that besides talking about fairness, we should actually also be talking about health equity. So fairness, as you may know, is defined as equal treatment and is actually a concept that also is a lot in computer science. If you think about counterfactual fairness, for example, where you look at if people have been treated equally, like if you would say something like women should have the same outcome as a man, for example. That would be like some example of counterfactual fairness. But the question is equal treatment actually the right goal in healthcare? This is like one of my questions. And this is why I would also like to talk about health equality and health equity. So what does health equality and health equity mean? Health equality actually is defined as the distribution of the same resources and opportunities to every individual across the population. That means that is actually our concept of fairness that we have, that everybody is getting pretty much the same, right? Equity, on the contrary, is defined as the customized distribution of resources and opportunities across the population to ensure no subset of groups are at a particular disadvantage over others in achieving the maximum potential, writes Korapati. That means in the concept of equity, you would give actually some people more than the others because you think that they are kind of, for example, more marginalized or more discriminated against. And there are some scholars within public health research dealing also with AI that say that actually health equity is something that we should aim. Smith et al., for example, write in the bulletin of the WHO that first we should design and implement artificial intelligence technologies such that they do not create, sustain, or exacerbate health inequities, which is of course clear, and we don't want to have any bias there. Second, we should design and implement artificial intelligence technologies such that they actively work to redress or eliminate health inequities or otherwise promote health equity. So I would say like fairness is just the beginning, and actually maybe the ultimate goal would be to reach health equity, if this can even be done, of course. If artificial intelligence is the right tool to do that. So we've heard already about many different challenges that we face when we talk about medical AI or AI in healthcare. There's just like some of those challenges. I propose to use Gordian knots as metaphor, because for many of those, I see that this kind of dilemmata that is really, really hard to solve, right? So it's kind of inherent in these dilemmata that it cannot really be solved because it lies in the problem itself that it is really hard to be solved. So for example, so this is just examples, there's many more. There's technical challenges like the black box phenomena and of course statistical constraints. We heard that machine learning is pretty much statistics, so we have this way, a statistical way of thinking, which is kind of hard to overcome. Maybe, we don't know, with quantum computers it will be possible, but it's not sure. And this results in quantifiable information or data being like hierarchically more worth, let's say, than not quantifiable information. Also, there is this challenge of these interdisciplinary challenges that, for example, Kevin in his talk showed us very nicely, right? So that there's like different disciplines coming together and trying to figure out things, but it's really hard for them to understand each other, for example, or to even listen to each other. And then there's, of course, the question, is a technical solution actually the right solution for a systemic problem, such as discrimination, like systemic discrimination? And that is also a very, very big question. So these are all very interesting challenges, but I will today focus on the dilemma that I call participation versus privacy, which I think is one key dilemma if we think about marginalized people or about minority population. So very, very quick recapitulation how machine learning works on the example of supervised learning, because I will, my argument will deal predominantly with the data. So this is why I will explain this very shortly. So you have like a labeled data, you have data which has to be labeled in the medical field. It's usually done by experts, by doctors, for example. And to have, of course, they provide the labels. And with this data, you have then, you model then your algorithm or your AI system, and you use like your training data to model the system. And then in the end, you have hopefully the goal that you wanted to achieve, for example, prediction. And you would validate this until you are happy with it, and then it would go out in the real world. This is like a very, very, very simplified version of what is actually done. But here you see already that there is like some aspects which would influence very much the outcome, the quality of the outcome, the quality of the prediction. On the one hand side, it's the quality of the data that you put inside, the quality of the data that you use for the training, and then also like the people who are like the expertise of the people who label the data, but also the expertise of the people who train this whole system. And so if we kind of combine this with the question about a minority population, it is of course the question, so where does this data, the training data, which in the end will then say how well this system works, where does this training data come from? And this question is institutionally and also individually. So where is this data collected? Is this data collected in a hospital? Is it collected in a private practice? Who is actually going there? Who is patient of these institutions, right? So like some people will, with more money, will maybe go to places that are more digitalized than others, or have a higher quality or better trained personnel, for example. So in the end, it is the question, which person makes it into the training data? So put it very, very in a very simplified way. And also not only like it's on the one hand side, it's the data that has been there all along, or the data that is even can potentially be there because it actually exists. And on the other hand side, it's of course the choice that the computer scientist makes in the end, what she puts considers relevant for the training data. So on the one hand side, it's the access to healthcare and the type of healthcare, but then also the decision about what is relevant, what constitutes relevant data. So this brings me to the point of participation. So missing data can be missing because there is actually some groups of people have lower access to healthcare or healthcare institutions with a higher degree of digitalization. So there could be people like refugees or people who have no health insurance, maybe don't even go to hospitals at all, or take or go to places which are not really highly digitalized, let's say. And there's also, of course, sociocultural differences in the use of healthcare and in the use of regular checkups or preventive care. And we know, for example, also that LGBTIQ people, for example, that many people, like, for example, lesbians don't really like to go to the gynecologists, for example, or like trans and inter people have bad experiences with healthcare and would maybe rather not go to some sort of regular checkups. And similar is true for POCs, which and also lower socioeconomical people with lower socioeconomical status, that they maybe go to the hospital like pretty late, and there is not so much data existing about them, or the data is very different because they would go to the hospital once their situation is already pretty bad. And also this question is, I talked already about this aspect of, which is also been said, called crap in, crap out. So like if you had bad quality of data, in the end, the results will be not fitting, will be bad. And so the question is of whom do you have high quality data, right? Of which population do you have a high quality of data? And do you have high quality data about minority populations? And I would guess, and it's not just me, it's also others, it would think that data about minority population could have minor quality, and that is because of different aspects. So once I've already heard, like this access to the institutions is the question. So maybe I mean, it depends, of course, also on the insurance system and the whole healthcare system, but in some countries, people who have certain insurances have only access to maybe to institutions that have not so well trained personnel, so that maybe the measurement error, the classification, misclassification and misinterpretation that could occur is way higher than with people that have maybe a lot of money and can go to highly specialized places which are like highly digitalized. Also, there usually is a lack of awareness and knowledge about minority populations and their specific health needs, if there are any. So we know that data is collected in the context of a flawed and unjust system. And this means that like a lot of discrimination, a lot of stereotypes also make it in the data. And sometimes also knowledge is not there that you could even see if there would be specific health needs, and you could not record that, and this kind of being also sort of discrimination. So this is this historic dimension of data, that we have like data of the past for the prediction then, for example, and we would predict into the future, right? And if the data of the past has kind of is very stereotyped, biased, has discriminatory potential, then of course our predictions would also be have a similar quality. And also very often, and we see this also above all in Germany, I think data about certain categories is not even collected. For example, like data about race would not be collected in Germany because, of course, of historic reasons, but that means also you would not have any information about that. And then, of course, some minority populations are also like really small. If you think about intersex people or transgender people, they're like not many. So even if you would have data about them, it would be still not a lot. The data volume would be small, and we will see statistically, of course, this makes a difference, right? So if you have like a very small amount of data, it's questionable how good the quality of your assessment would be in the end. And one more aspect about missing data is, of course, some populations may also refuse, maybe also rightfully refuse, to be part of a data bank or to take part of this. Like we know about the digital divide, that some people just use less smartphones, less wearables, also less computers, have no access to places which are like highly digitalized. But also some populations may not be interested in sharing the data because they have a history of bad experience with medical institutions. We know this of POC, people of color, who have been taken advantage of for data production. We heard this like in the last days that, you know, like clinical trials have been made on people of color without them knowing. So why should they even care about sharing their data? And also data has been used for surveillance and is still being used for surveillance on people of color. So there's maybe this yeah, there's maybe not so much interest if one can choose to share data. And also, like we know of intersex and transgender people that they have been pathologized for a very, very long time and may not be interested in like taking part of that. So some statistical features I also find very interesting, because we know like machine learning is all about statistics. Like the more data, there is of course more data about the majority, who is also more likely to participate in the use of AI. And also, and this is very important, the performance metric of in machine learning is accuracy. That means that you would like to have like a very high accuracy, which you can of course reach if you take like the majority and fit it to the majority. It gives you a very nice accuracy, but of course for all the outliers, let's say for all the smaller populations, you will have a very, very bad accuracy. So this means both of these aspects privilege actually the majority, which will have a higher quality results, and the small groups which maybe will not be considered or have less results with lower quality. So let's come to the privacy part. So how relevant is a privacy data protection for minority population? We could say that health data is regarded as sensitive data, although the GDPR is a little bit vague, let's say, about that. They would say sensitive data about health data would just be like data about genetic illnesses, but still, like commonly speaking, informally speaking, it's sensitive data. Minority population, of course, are especially vulnerable because the exposure might lead to additional discrimination. Members of a small group are less well protected because individuals are easier to be identified. You think of intersex people, and there were just a very, very few. It's very easy that they will be identified, of course.
4 minutes.
And thank you. The GDPR also speaks about vulnerable data subjects, and let me come back to that. So what are the risks for the minority population is, of course, the risk of data leaks, about the risk about outing. And I'm thinking here about, for example, about LGBTIQ people. It could be a passive outing, so that it's not really just happening by chance, let's say, or forced. And the people could have disadvantages then in other areas of life, like job prospects, housing, etc. And then there's, of course, the risk of surveillance when we see, for example, people of color or refugees and so on. So that means that actually the minority population has a higher vulnerability to come back to these vulnerable data subjects. So what is the dilemma? The dilemma, the premises, of course, are that there is a difference between people which is big enough that taken into account would lead to different results, which are machine learning tools. So if there is no difference, health-wise related, it wouldn't be a problem, but if there is, you maybe want to know. And the minimal condition we know in statistics is to be represented in the results. You have to be part of the training data because you will not be able to be considered otherwise. So what does this mean? So to be able to stratify also for a category, I need the related information. So to be able, for example, to show a human bias on people of color, I would need the information about people of color in the data because I could not stratify for that otherwise. That also means that actually more information about categorical association is needed to find relevant categories if you don't know that yet. So we know that there is like, for example, gender medicine, which deals with, or sex-based medicine, which deals with health-related difference between men and women. But there's like, but they know, they have already quite some knowledge, but there's many, many categories where we don't know a lot about what makes the difference. Is there any difference? Is there any ethnically related difference or age-related difference? So what we actually can agree on is that like fairness or health equity would actually lead to the collection of even more data, because if you have to have this category, this information about the categories to show a bias, you need to collect more and more data about the people. And we see this also. Thank you. We see this also in the case of precision medicine, right? You need a lot of data for even more individualized medicine. You have to collect lots of data about people. So this is my last slide. That means once a person is part of the data, of course, there is the risk to be exposed or subject to surveillance. Members of a minority population would have to make themselves even more vulnerable to be able to participate, right? So they're already discriminated, but then to be able to take part of this whole, let's say, data-driven healthcare, if they have even the possibility to choose, which very often is not the case, then they would have to make themselves even more vulnerable and kind of trust this whole system that the data would be safe there. Also, what we know, and it is spoken about, that fairness could be used as an argument to collect more data. This is also like a critique about the whole concept of fairness. And then my last question is it even ethically sound to ask vulnerable groups to provide data, knowing all this? So these are my references, and thank you very much for listening to my talk. And I'm very curious about your questions.